As Stephanie said, just a declaration of interest, I am Director of AestheticSource. Back in the 1980s, I worked in the NHS in dermatology, and in the early 90s, I joined the aesthetic arena. So today, my session is going to be very much about aesthetic dermatology, very much looking at what we can achieve with gentle chemical peels. And I'm going to look at the idea of not just peeling, but peeling and also restoring the epidermis and the dermis and dealing with the photo damage that we're looking at. We've also got 2 patients who've come through for chemical peel treatment who are going to be treated by my colleague Caroline in the back. So I've got some slides to show you, and at some point while I'm doing my presentation she will come up on the screen and I will talk through what she's doing and how simple and easy it is to do these mild chemical peels. So we're going to look at consultation tools, we're going to look at practical peel application, and very much at an evidence-based approach. From my personal practice, I like to see published clinical data of anything that I'm going to talk about. And I'm not talking about something in the Daily Mail or just a single patient study, but looking at single ingredient, randomized, double-blind placebo-controlled studies and final formulation randomized double-blind placebo-controlled studies, which in the cosmetic arena are very difficult to come across. And one of the things I'd like to just stress is the difference between a cosmetic and a pharmaceutical. And I know that seems like really going back to basics, but can anybody in the room tell me what a cosmeceutical is?
It's a marketing term.
Absolutely, it's a marketing term. Okay, a cosmetic is something which is licensed by the EU Cosmetics Directive. Okay, and that is any form of cosmetic. A pharmaceutical is something which is prescribed, and there are no other legal categories. Okay, 10 or 15 years ago we talked about cosmeceuticals, and we understood that what we meant was effective cosmetic ingredients, things that actually made a difference to the skin. Unfortunately, the marketing people have got hold of that phrase, and I was at a show a couple of weeks ago, Professional Beauty, and I was amazed, walking across the floor at Professional Beauty, how many cosmeceutical companies there were. And I was perhaps unfair and went and asked a few people what was in their cosmeceutical, and wasn't terribly impressed with some of the answers I came back with. So just remember that we're talking here about cosmetics, not cosmeceuticals. They don't really exist. So, consultation tools and peel procedure. I'll watch for the middle slide coming up there. So I'm going to talk to you a little bit about peeling background while we get set up in the back. So let's have a look first. Why are we using peels? My training historically has been that we're using peels to peel away the skin, whether it's for anti-aging or the other indications that we can use peels for. But actually what we're really trying to achieve, and what our clients, our patients are asking us for, is healthy skin. They want skin health. So just taking away layers of skin, taking away segments of skin, isn't what they're really looking for. They're looking for a rebuilding of that dermal matrix. They're looking for restoring of the epidermis. At the end of the day, what they're looking for is to reduce fine lines and wrinkles. And to do that, exfoliation is a good way to start. If at the same time we can achieve some pigment evening and we can reduce the appearance of blemished skin, then we're going to have happy clients, happy patients. We can do more than that. We can look at supporting other treatments in clinic, and some of the photographs I'm going to show you later on are combining peels with other modalities. So combining peels with medical microneedling, combining peels with laser, combining peels with injectables, with fillers and Botox. We've actually got a neat little book, if anybody is interested, where we go through category by category the sort of patients who come into our clinics. So a patient with photo damage, a patient with Fitzpatrick type 5 skin who's got some hyperpigmentation. And in each of those cases, we look at published clinical studies and we can show you photographs of a specific patient with before and afters and tell you what skincare treatment they had at home and what series of peels, what strength of what particular peel ingredient that they had. And that's a brilliant consultation tool for you to use in clinic when you have a patient in front of you and you want to be able to show them exactly what you can achieve. If you don't have your own bank of photography, and many people don't, it's an extremely good resource because you really can show people precisely what can be achieved, and you know that these photographs are from published clinical studies. And the reason I stress that is that what's important about that is that we know that the photographs haven't been doctored. They've not been doctored by a client being shown as having had a peel, but also they had a few other things on the side, and they haven't been doctored by Photoshop, which is amazing. We can do an awful lot with Photoshop. We don't. These photographs are from peer-reviewed published clinical studies in journals such as JDD, or their abstracts through the American Academy of Dermatology. And I'm also going to show you some pictures which show peels in combination with home care, so you can see what can be achieved in total. So first of all, just to look at the use of peels. Peels have been around for a long time, as we know. I'm not going to go into the history of peels. I think we've covered that enough times before. But just looking back, this is 2013, and yes, botulinum toxin was 3% up from 2012, 6.3 million people. This is data from the American Society, from ASAP, American Society of Aesthetic Plastic Surgeons. If you look at chemical peeling, 1.2 million chemical peels performed in the United States, and that also was up 3%. I think if you look at the UK market, we don't have such strong data, sadly. It would be wonderful to have data like this, but we don't have it. But there is certainly a significant growth in the amount of chemical peeling being performed in the United Kingdom by the various different people who are licensed and legally allowed to perform chemical peels. So what is the definition of a chemical peel? Well, the definition of a chemical peel, and I'm going to read here from the American Academy of Dermatology, the guidelines are chemical peeling for the treatment of certain cutaneous diseases and conditions and for aesthetic improvement in the application of one or more chemical exfoliating agents to the skin, resulting in the destruction of portions of the epidermis and dermis and the resulting regeneration of new epidermis or dermis and new epidermal and dermal tissue. That sounds quite grandiose, but let's have a look at what we can actually achieve. So the first thing we need to do if we have a patient coming in for peels is make sure that they really understand how to take this journey well together. If you take the patient journey well together, these patients will come back for years and years. And in terms of topical treatments, one of the things I learned very early on with my chain of clinics was that if people come in and have a very successful injectable treatment with me, they are so unlikely to sit down over lunch with their girlfriends or their male friends and say, yes, I go and have Botox, yes, I go and have dermal fillers. It's not something people say. And I did at one point say to a customer of mine, her name was Julie, and I said to her, Julie, I'd really appreciate it if you told your friends about the skincare you get from me. And a few weeks later, I had a patient come in and she sat down in front of me, a new patient, and I had all the records in front of me, did all the great consultation, and got to the point of, and what can I do for you? And she said, well, my friend Julie comes to you and her lips are amazing. Please, can I have some cream? So I had to explain to her that actually that's not what we were going to do to change the shape of her lips. So if you really negotiate with your patients beforehand, correct assessment, correct tools, so they understand what they need and they understand what you can offer, then you will get a great patient journey. And I'm talking about not just using skincare, but skincare, peels, lasers, injectables, surgery, and also onto other things that we can talk about. Nutritional advice. Are your patients drinking sufficient water? Do you actually look at the hydration in their skin to see if they are drinking sufficient water? Do you talk to them about what they're putting into their bodies? Because that really does reflect in what their skin looks like. And psychological support as well. I don't know whether any of you remember, Dr. Tracy, you may well remember, years ago, a wonderful spoof paper for the collagen injectables, we're going back to the 1980s here, where they showed a direct causal link between injecting collagen injections and divorce, which isn't a case at all, but it was a wonderful spoof. But good consultations are key, and it does take time to make these consultations. What consultations tools do we have? Well, we have mirrors. We can all look in mirrors. But I find if I give my mirror to a patient, they sort of flick their hair and look at themselves, and they focus on one wrinkle. Okay? So I try and get my patients to look in a big mirror, not a little mirror. But a big mirror still reflects back on what they're looking at. I find that using a camera is the very best way of taking photographs of my patient, because if you sit your patient in front of a photograph of themselves, they are so much more critical of what they're looking at and so much more realistic and less distracted by what their hair looks like or whether they have the right colour lipstick on. It's very, very interesting, and I'd love someone to do some studies on that at some point. And there's a picture here of a woods lamp as well. One of the other tools that we can use is scanning equipment, things like the Visier scan, the Stratum scanner, and it possibly, if we get the feed coming through from the back, we'll be able to show you an assessment of somebody having a photograph taken where we can show the wrinkle count, hyperpigmentation, we can show vascular lesions as well, so we can pick up all sorts of things, but really help to diagnose what our patient's condition is and exactly what peel we're going to use. So this is a close-up of a peel, of a scan performed recently. So let's look at some of the chemical peel agents that are available to us. Alpha hydroxy acids, things like glycolic acid, citric acid, lactic and mandelic acid, we'll come back to those. And BHAs, beta hydroxy acids, ingredients such as salicylic acid. We have TCA, we have phenol, and we have combinations. Now for this afternoon I'm going to be talking more specifically about the alpha hydroxy acids. If anybody wants to talk more about the deeper peels, the stronger peels, please do come and we'll have a conversation about that later as well. So looking at glycolic acid, why do we use glycolic acid? Well, first of all, just a quick note on history. Glycolic acids were discovered in the 1970s by two doctors, Dr. Van Scott, who is a dermatologist, and Dr. Yu, who is a dermatopharmacologist. And they discovered the keratolytic effects of hydroxy acids in a paper that was published in 1974. And what they found was that with glycolic acid, we can increase the exfoliation in the skin and we can increase cell turnover. And to our customers, our patients, and I do use the word customer because we all have businesses, so customers or patients, they're looking for softer, smoother, clearer skin. So something which will exfoliate and increase cell turnover is going to give you that. Pigment evening. Yes, great, we want pigment evening. Our patients want even skin tone, and we can produce that. They want to reduce the dark spots in their skin and increase clarity. We want to increase glycosaminoglycans, and this is going back to the idea of not just taking away from the skin, but using peeling ingredients that are going to add back to the skin at the same time. So volumizing and plumping the skin, that's something which patients ask for all the time, because if you volumize the skin and you plump the skin, you're going to reduce the appearance of fine lines and wrinkles, which is what patients with photo damage have come in to request. We can increase collagen. We've got data, I'm going to show you some data on neocollagenesis to firm and hold the structure of the skin so the skin looks plumper and younger. And that visual plumping and firming with a younger, more elastic looking skin. And all of the references here, if you want any of the papers, have a look on PubMed, Medline, or we can help you to find those papers. Looking at citric acid, this is another ingredient that we use for brightening the skin. So this would be a separate peel applied first before the glycolic peel to reduce melanin expression in skin cells. And we can significantly reduce melanin expression by using citric acid. Citric acid will also exfoliate and do a lot of the things that the alpha hydroxy acid, glycolic acid, is going to do. If we look further at that histology study, this was only 6 patients, but they were aged 70 to 83, and they were exposed to 20% citric acid at a pH of 3.5. They had this exposure over 3 months, twice daily on the use of their arm, so this is a topical use rather than a specific peel use. And if you look at the changes in the skin, my arrows have disappeared all over the place, so please, I apologise for the arrow movement. But anyway, the clinical findings were an increase of skin thickness of 16.3% compared to the vehicle, where the skin was actually reduced in depth by 4%. And when you talk to patients about doing alpha hydroxy acid peels, you'll often find patients coming in and objecting to the idea because, oh no, hydroxy acids, they thin the skin. Well, there was a paper once that showed thinning of the skin, but it showed a specific area of the skin thinned, and it was the stratum corneum that was thinned, and it was thinned because it was normalised. Okay? It was reduced back to its normal youthful level as opposed to the older skin that had been peeled. So we were thinning the area of the skin that actually needs thinning, but we can see here, and I can show you the same data for glycolic acid and mandelic acid, that we are increasing skin thickness. So you can say with absolute conviction, if your patients are worried that alpha hydroxy acids thin the skin, no they don't, they thin the stratum corneum, but they thicken the total dermal depth, as you've seen here, by 16%. And the epidermal thickness was increased by 40%. Epidermal hyaluronic acid was up significantly, and dermal hyaluronic acid was up 57%. Now, 57% increase in dermal hyaluronic acid is a significant sum, and that's going to make a big difference to the patient's skin. And dermal chondroitin sulfate was up 66%, so even more. Now, mandelic acid, this is another ingredient that we use for peeling, and it's getting increasing interest. Mandelic acid used alongside salicylic acid is very useful. Salicylic acid is very well known for its effect in the skin. It's extremely popular and well used because of its ability to reduce sebum production. One of the side effects of salicylic acid is that it dehydrates the skin. It reduces the total water content of the skin. And a dehydrated skin sadly produces more oil, not more water. So that's how we get the sort of high street rebound acne, where patients are using too much salicylic acid and they're struggling with that. If you add in mandelic acid to your protocol, then you're going to find mandelic acid reduces sebum production very, very, very quickly and very well. But it's also a humectant, so it increases the water content in the skin. So for peeling, mandelic acid will give you a really lovely result. It's a very similar molecular structure to glycolic acid, but it's more lipophilic, so again, it's very suitable for patients with oily skin and acne-prone skin. If we look at the sebumeter measurements, you can see here we're comparing mandelic acid with salicylic acid and benzyl peroxide cream, with the mandelic acid in blue. So you can see you're getting very, very similar results, if not better results, in reducing sebumeter count than with the benzyl peroxide or salicylic acid. At the time of the treatment, so Caroline has taken off the makeup, she's prepped the patient first of all with a facial cleanser, with a very gentle polyhydroxy acid gluconolactone cleanser, which will get rid of everything from the skin, all the makeup, etc. And then she will second prep with a pre-peel pre-peel cleanser, which is a solvent surfactant. So that's going to reduce all of the surface oils from the skin, any cellular debris, and get rid of that. The next thing she's done is just protect the eye area. Now you'll note, and this is something which is actually controversial, one of the things that we teach in peeling now, when we're using the gentle hydroxy acid peels, is not to put any occlusion, any protection over the eyes while the peel is going on, because we did some research which looked at the insurance and the number of burns that we'd had, and people are much more likely to get a superficial burn in the eye area from a peel which has been applied with gauze or other protective means over the eye, because the peel can leach in underneath and then it doesn't get neutralised afterwards. So much better to get the patient to close their eyes, and we should not be spilling our peel. If you do spill the peel, you need to wash with a saline wash immediately and neutralise, but it's something which we just simply don't do. So she's having the peel applied. We're using a glycolic peel here. I would imagine that we're using a 20% peel. And one of the interesting things about hydroxy acid peels, again, is that we always traditionally have talked about percentages of peels. Now I can walk along a high street and go to different pharmacies and collect a range of glycolic peels from 10% up to 70%. But the pH will range from 0.6 up to pH 5. Now pH 5 ain't going to do very much, okay? But I can actually specifically say, right, I'm going to shop for 70% peel today. And with 70% peel, I can find peels with a pH that varies between 0.6 and 5, okay? So if you're taking on a peel range, be very careful to understand whether you're using a buffered, a partially neutralised, or a fully bioavailable peel. Here, with the product that we're using today, this is fully bioavailable. So the pH of this 20% is pH 1.6, which is significantly lower than a lot of 70% peels that are available on the market. The peel is applied for a maximum of 5 minutes exposure at any one time. So this client will have this peel on, the timer will be going, we'll be waiting for the 5-minute count. While the peel is on the skin, we'll be watching very carefully to see if we see any redness appearing or if we get any epidermolysis. If we get epidermolysis where the tissues have separated or the fat is denatured, that means that it's time to neutralise the peel. So we take our neutraliser and spray it on. If we can, we take the patient up to 5 minutes. Okay, so we really want to see this peel on for 5 minutes if possible. The peel procedure is 6 peels. We always start with 20% peel, and the second time the patient comes in, which should be around 4 weeks later, 3.5 to 4 weeks later, because we want to allow for the epidermal cell turnover. When the patient comes back in again, if the 20% peel had been left for 5 minutes first time, then the second time they come in, we go up to a 35% peel. Unless we're going to use either a citric or a mandelic peel. If we're going to use a citric or a mandelic peel, we will apply that first when they come in for their second peel, leave it for 2 minutes, and provided that we haven't had to neutralise for any reason, we'll then apply a glycolic peel for further 5 minutes. The next time they come in, we can do exactly the same procedure, so 2 minutes of either the mandelic or the citric acid, and then we apply the glycolic 35%. and then the subsequent time we do the Glycolic 50, and then we have the Glycolic 70% peel. Now, the reason that Caroline is continuing to brush the patient is interesting, and this is something we've done a lot of research in the United States, looking at the best way of getting your patient to achieve 5 minutes of a peel. She's using a dry brush to brush the skin. Often we use a cold air fan, cold air blower or a fan, and patients find that quite alarming because there's no contact. They've got their eyes closed, they've got acid on their face, and they've got a machine blowing cold air at them, and they can be quite nervous of it. Gently brushing the skin with the brush does not affect the glycolic peel, but it says something very important to the patient, and that is, I'm right here, I'm right beside you, don't worry. And I'm going to echo what Anna was saying earlier about local vocal, or vocal local. The voice is a very, very powerful tool to keep your patients relaxed and calm while the peel is on.
Can you just go over that again? So, first of all, you prepare the skin, then you apply mandelic acid, what percent?
The mandelic acid is the 30%, and likewise
what
with the citric
pH
acid.
is that?
pH 2.8 for the mandelic acid. No, sorry, 1.6 for the mandelic acid in this particular case.
And then
And the
how
citric
long do
acid
you
is
leave
also
that on for?
2 minutes.
And that's the same each time they come, is it?
Absolutely, except the first time. The first time we would just do a glycolic acid.
Okay.
The second time you
And
would
then,
have the mandelic.
and then each time you apply glycolic acid in increasing strengths.
Absolutely. So the mandelic acid or the citric acid. Mandelic acid for patients with oily skin and acne. Citric acid for patients who have any hyperpigmentation or they want to even their skin tone in any way. And also for thickening the skin, as we saw earlier, that slide showing 57% increase in hyaluronic acid. So always the same dose of the citric acid or the mandelic, but an increasing dose of the glycolic acid. And there are people who will do just the citric acid or just the mandelic, particularly if you've got a patient with a very sensitive skin or a younger patient who's acne prone with oily skin. They would very much benefit from a course of mandelic peels. So as you can see what's going on now on the main slide, you can see that Caroline has now put protection over her client's eyes, her patient's eyes, and she's got the Neutraliser spray, and she's going to spray that on. So we have an alkali spray going onto the acid, alkali and acid combining. In this case, we're going to produce carbon dioxide, which is going to give you a foam, and that's lovely because it gives you a great deal of satisfaction and reassurance for you and for your client that if you spray on the Neutraliser and you don't get that foaming, you know that the patient is neutralised already, so it's a very simple technique. So we're just dabbing to make sure that we're not dripping too far and spraying the Neutraliser onto the skin. Once the client has been neutralised, what Caroline's going to do is to then put a cold water compress onto the patient's skin, just to take down the temperature of her skin. If she's feeling a little bit red, feeling a little bit hot, just to cool the skin down. And then she will apply advanced hydroxy acids onto the skin. So the first thing that will go on will be lactobionic acid, which we'll look at in a moment. Lactobionic acid is a very interesting polyhydroxy acid, third generation hydroxy acid, extremely humectant. And we have the confidence that, in fact, in the United States, lactobionic acid is part of the wash that's used by the transplant teams. So when they take the organ out, because of lactobionic acid's very powerful metal chelating abilities, it's used there. But it's used in topical skincare and can be used immediately post-peel for healing. And then obviously we're going to apply a very high SPF onto the patient's skin afterwards to protect the skin. So, the benefits of an alpha-hydroxy acid peel. They fill a skincare and a cosmetic need that's not met by other cosmetic treatments. We're reducing epidermal turnover time, we're optimising keratinization. We're increasing both epidermal and dermal thickness. We're diminishing the appearance of pore size. And how many patients come into us saying, I hate the size of my pores? Knowing that we've got clinical evidence to reduce the appearance of pore size is great. And we're helping improve dull skin tone by enhancing the natural glow of the skin. We can enhance the benefits of other treatment modalities, preparing the skin for better results of stronger peels. And something that we quite frequently do is to use a course of glycolic peels to prepare somebody for a TCA peel. And believe me, you get significantly better results with less downtime with a TCA peel if you prep the patient with glycolic peels first. And also we have a product which is completely customisable to treat a wide range of patient types and concerns. With glycolic peels, we can peel patients with Fitzpatrick skin type 1 through 6. Okay, remembering also at the moment we have this difficulty that often patient skin type in colour doesn't reflect their Fitzpatrick skin type because we've got so much mixed race going on at the moment, and we often find that patients respond differently to a glycolic than we expected or we maybe would have seen previously. We can progressively increase skin exposure time of the glycolic to improve the efficacy of the peels that we're doing, and we have an option to apply multiple layers of peels. But also we can bring new patients in. We talked about Julie earlier on, but different demographics of patients into a skincare practice. And these patients are tomorrow's laser patients, they're tomorrow's surgery patients, they're tomorrow's injectable patients. So what can we expect following a skin tone? Acne scars can be visually softened by glycolic peels. Diminished pore size, improved natural glow. And if you look through this list, if you read through this list, this is what clients are coming into our clinics and asking for. But let's go back to a little bit of sums, a little bit of business, because business is important to me. Glycolic peels are not expensive. You can buy a peel bottle for around £30. 20 peels out of that bottle, which means your cost per peel is about £2. Okay? Now, if you're charging £75 for your peel, and £75 is the average UK price for a glycolic peel, and you have a patient who comes in and has a course of 6 peels, that brings you a revenue of £438. If you have 20 patients, or so 25 patients coming in and having that course of peels, that brings you over £10,000. And these are patients who are lying on your couch, your treatment couch, who are there to be talked with, and you can talk with them about the other treatments that they can have. Remember, these patients aren't just going to have peels, they're going to have home care as well. Your margin on skincare should be around 100%. So if your client's spending about £200 every 3 or 4 months on their skincare, which is what a lot of people do spend on their skincare, if you walk into John Lewis or Harrods and ask for a moisturiser, you may well be asked to spend £300 or £400 on a single pot of something which has no clinical evidence whatsoever. So convincing your patients to spend a couple of £100 every 3 or 4 months on something which does have clinical evidence shouldn't be difficult. And that's on top of your peel revenue and on top of the other things that you're doing in clinic. So the benefits of alpha hydroxy acid peels: proven results over 25 years, definitive clinical proof, and photographic proof as well. I'm just going to go back to that slide and just talk about patients we don't treat. So we don't treat patients who have active cold sores, active herpes simplex. We don't treat patients who've had Roaccutane, oral vitamin A within the last 6 months. We don't treat patients whose skin is still healing for any reason, whether it's surgery, whether it's radiation. We don't treat them. And also, one of the things which is very, very important is don't treat them if they have insufficient sun protection. If my patient hasn't bought a sun protection factor from me, I will not treat them unless they bring in the treatment, the SPF that they're going to use. I take it very, very seriously. You have to have an SPF after a peel. Although actually there was a clinical study done to look at what level of SPF you need to mitigate the reduction in the stratum corneum, i.e. the reduction in the barrier, the skin barrier effect of using alpha hydroxy acid peels. And the SPF you need to mitigate that is an SPF 2, which is remarkably low. But nonetheless, I would still recommend using an SPF 30 to 50 for your patients who are having peels. Cautions: be very careful with chemical peels with patients who have hair colour. Now, it's only immediately on the day of the peel. If patients come into you and they've just walked out of the hairdresser and they've had a chemical hair treatment, whether it's a perm or a colour, they still have chemicals on their skin. If you're going to then expose them to further chemical treatment, you're not going to know what to expect. So make sure your patient has washed their hair at least once, preferably twice, after a hair colour. And likewise, if they have their peel done and then they're going off to have their hair coloured, they will still have chemicals on their skin. You don't want to be putting hair colours or perming equipment, perming chemicals onto your patient's skin. They don't want to be doing that immediately after a peel. Also be cautious with semi-permanent makeup. We do have no data to show that semi-permanent makeup can be damaged by peels, although there is anecdotal evidence, or a rumour, shall I say, that maybe it does, but certainly I've never seen, and I've treated an awful lot of patients who have semi-permanent makeup with glycolic peels, no problems at all. Be careful also with topical vitamin A. It can sensitise the skin, and you can find a glycolic peel on a patient who you've treated for years, had no problem, and suddenly they've gone and they've bought some vitamin A off the market, stuck it on their skin, and you get a very frank reaction to a peel and need to neutralise very quickly. So do be aware of that. We've talked about SPF, and avoid heat as well. One other thing with peels is that peels can damage cheap jewellery. Okay, glycolic peels would damage cheap jewellery, and I would probably advise you not to ask your patients if they are wearing cheap jewellery. I would advise you just to ask them to remove their jewellery straight away. It's a much nicer way to approach patients. So when the peel goes onto the skin, immediately you'll feel some stinging and burning. You may see flushing, erythema for the first hour or two. If your patient is properly prepped, that shouldn't continue. If your patient isn't properly prepped and they are sensitive to glycolic, that redness can go on for several weeks. So be very careful to make sure that they're properly prepped. Watch out for epidermolysis. That's where you see whitening in the skin. If you see whitening, you want to immediately neutralise. But beautifully, you can spot neutralise. So you can pick up the spray and you can either spray it onto a little bit of gauze and spot neutralise with a touch, or you can just spray onto that area, dab, and then the peel can continue to work elsewhere. Okay, combination protocols. Microdermabrasion, needling, injectables, other treatments. How am I doing for time? All right, okay. Yes, okay. So, I'm going to take you through now some case reports. So these are the clinical studies I was talking about earlier, and they do come from a book that we can provide for you if anybody would like further copies. So we're looking at combining treatments with other modalities, and this is a dermatologist-used study, and this is a result after 4 20% glycolic acid peels and 4 medical microdermabrasions. And you can see significant changes in the skin after 16 weeks. Here we have a patient who has treatment both with glycolic peels, dermal filler, and botulinum toxin type A. Again, you can see significant changes to her skin. And if we look at exactly where she's had treatment, you can see Botox to the glabella, dermal fillers to the nasolabials, but effects on her skin tone. And if you look more closely in the eye area of the same patient, you can see there where, without having Botox for the fine lines and wrinkles, so this is looking at the static lines, not the dynamic lines, you can see a significant improvement in skin tone in the area underneath her eye. Here we have a patient who's had simply glycolic peels, so this is not a treatment combined with anything else. A 66-year-old patient who had a 35% peel followed by a 50% peel and 2 70% peels. Bear in mind that in the UK, we do recommend that you start with a 20% peel. This patient started with a 35% peel. And this was used in conjunction with home care, so the patient had a cleanser and an eye cream to use twice a day, and in the morning was a specific day cream, and at night a specific night cream. Here we have further treatment, a patient using glycolic peel for teenage acne and pigmentation. And for acne and scarring, significant results. Now these patients are in clinical studies, so they are not allowed to be using any other treatment. If they are using any treatment, it does say so in the section below. So I'm going to go through them fairly quickly because I know that I've come to the end of my time. This is mandelic acid and glycolic acid used in combination. Further patient with mandelic and glycolic as well, used as per the protocol we discussed. And teen acne. And acne scarring, pigmentation and erythema together, treated with glycolic acid, 3 peels in this case. I've got about 5 slides to go. Just bear with me. Okay. This is a patient treated with inflammatory acne and rosacea. An interesting peel. Obviously, this was treated in the United States with Clarin lotion and oral antibiotics, which were discontinued at the 5th peel. So even with patients with rosacea, which is counterintuitive in certain cases to use something like a glycolic, we can have some extremely effective results because we're normalising the skin barrier, and that's going to help to protect these patients. Okay. Post-inflammatory hyperpigmentation here with a darker Fitzpatrick skin type. And this is a patient with a very complex acne and post-inflammatory hyperpigmentation. Treated with 2% hydroquinone as well, bearing in mind that that's now not available as a cosmetic in the UK. When this study was done, it was available as a cosmetic, but it's banned by the EU Cosmetics Directive. A further patient with rosacea, and I'm just going to move to my end slide. These slides are available if anybody would like to see more. So thank you very, very much for listening.
That was so interesting, absolutely fantastic. One of the best talks I've heard on peels for a long, long time. Thank you very much indeed.